First, I want to thank you for invitation, Dr. Vasileva. It's very kind of you, and I'm so happy to be here in this audience. Second, to declare some things. First, I want to declare, sorry for my voice. I feel a little bit sick, but I declare that I'm not COVID positive. Third is that I'm not academic person, so I will a little bit step out from academic tone, but I will speak about very important things, and you will see. And let's start from beginning. I always start my presentation with this curve. This curve is for forgetting, and you will see on this curve that after an hour you will remember just only 40% of the presentation, and then after a week you will remember just only the title of the presentation and maybe only one slide. That's why I will start from conclusion of the presentation, and then we'll introduce the other things, just to remember what I want to say. But first, is something that to show you. This is one of very famous optical illusion that is called windows of Ames. And if you look on these windows, your brain, why you that these windows moving left and right, but it's really it's circulating. So this is just only to show you that when you see something that is not the objective true. That is maybe a little bit for previous speaker, when you see that is something different. And conclusion of my presentation. First is fertility sparing surgery exists. What is fertility sparing surgery? This is a very early stage of gynecological cancer to preserve fertility of the patient, to keep their reproductive ability for the future. Second conclusion is it is all about different point of vision. From one point, oncological surgeons, and from the other point is vision of the patient and vision of the reproductive specialist. This is maybe the where I must say that I'm not oncological surgeon. I'm a reproductive specialist, but I have a privilege to be part of the team working oncological surgery. At the head is Dr. Atanasova, which is here with me today. And third conclusion is fertility sparing surgery is not for every onco patient, but it's for every oncological surgeon. And the last is fertility sparing surgery requires multidisciplinary approach. I can't imagine our work without a oncological unit, without a pathological unit, without anesthesiologist, and about our obstetrician unit also. So every newborn baby has a father. This is the father of the fertility sparing surgery, that is Professor Dargent. Thank you him, 40 women from his oncological patient have their desired babies, and he established the rules of fertility sparing surgery. And I can say with a proud that at the moment in Bulgaria, our hospital is the only center who is participating fertility sparing surgery for oncological patients. And let's start. Before to see the rules, I will just only briefly show you a few cases from our practice. This is young woman with 34 years old, came to me one morning and asked me to save her uterus because he has stage 1A endometrial cancer, And many oncological surgeons in very famous clinic in Bulgaria offer her hysterectomy with bilateral salpingo-thoracotomy, but she wants to have a baby. And with consultation, after consultation with our oncological unit, we decided to try. And you see some views from operations that we did. We try conservative approach, and you see how it was mount by mount, making hysteroscopy. And of course, it was supported by hormonal treatment. Very high, I will talk about then after. And finally, we have a newborn baby with, which is delivered in our hospital after this endometrial cancer. The interesting was that after this, when she decided to accept our treatment, she was called from many times from oncological clinic and said, okay, you decided to have a conservative approach, but maybe you will die soon and you will be very disappointing from this. This is the many of our oncological clinic view for patients like this. And second, again, interesting case coming to us, one young woman, 29, and imagine she has 10 years amenorrheic secondary amenorrhea, and nobody can say why. They measure hormones, trying to find the reason. So we saw here one big adnexal mass, 6 centimeters, and prepare for surgery. You see the photo from the surgery here. That is the adnexal mass. That is the ultrasound. Of course, we during the operation, we sent a sample to our pathologist, but you know, that is from the practice. That was confusing for them what it was. They said maybe borderline, maybe granulosa cells tumor. And after first surgery, we wait for frozen state and see that is adult granulosa cell tumor. Immediately perform salpingectomy with oophorectomy from one side and preserve the other side. And nowadays, for 4 months, she has a regular menstrual cycle and many follicles in surviving ovaries. So that is a new beginning for her. And the third slide is very old, but that is laparoscopic nerve-sparing radical tracheoectomy. That is not our video. That is from friends of ours from India. One of the most famous oncological surgeon, Dr. Sailesh Puntambekar, who was in our clinic, and we visit him, and he teaches how to do radical tracheoectomy. And maybe you will ask me why we not have our own video. I will tell you why. Because we have several cases coming to us, but after this, after operation, with stage 1A, 1AB, 1B of cervical cancer, but after surgery. So many of these, nobody from oncological surgeon nowadays suggest to women to have a radical tracheoectomy. We are almost prepared for this, but we are looking for a patient who will take a challenge and will try to preserve fertility. Okay. And speaking about cervical cancer, I will briefly show you the guidelines. For stage, you see here that for early stages of cervical cancer, when you have a very small lesion, you can do the simple tracheoectomy or even conization. And for stages 1A2 and 1B1, and the small lesions less than 2 centimeters, that is very important. We can have a lymph node assessment and radical tracheoectomy. Of course, you ask me why that is not a practice when it's included in all guidelines of all famous organizations for this. I will tell you why. Because, first of all, when you do the radical hysterectomy for these small lesions, you take much more money from the funds than if you do just only conization or simple tracheotomy. That is the real truth, not only for Bulgaria, but for all over the world. And I just want to mention the other is transposition of the ovaries. Yes, many clinics in Bulgaria are doing transposition of the ovaries. Well done, guys, but many of them send us patients to preserve, for cryopreservation for all sites when they already done these transpositions. Funny joke. Why? Because the ovaries are here. It's very difficult for me to catch the ovaries. I'm doing, of course, this. But why they don't do this before operation or before to suggest operation? Because it's dangerous for the women. Funny. Because the cervical cancer tumor is not hormonal dependent. But nobody said that that will be if we're making stimulation of girls like this, we'll improve their stages. That is absolutely not true. And here is the guidelines for sparing treatment. Here we have a very, very important step. When you have small lesion, you must have intraoperative lymph node assessment. So the pathologist must say if the lymph nodes are included or not in the process. Well, you think that is just only one or two clinics in Bulgaria can do that. Yes, in our clinic we can do that. Thank you to Dr. Metodiev. But how to proceed when we don't have? Again, we spoke with Punta Bekar, how you work in that in India. Now they established a study for these small lesions for young women. They do the tracheotomy laparoscopically, make a lymph node dissection, and finish the operation. End of the story. Waiting for frozen state of the pathologist, and if there is involved the lesion, they may be grit involved the lesion, they making radical hysterectomy then after 1 week, or that is absolutely hot treatment for the women and preserve their fertility. Again, one slide will show you that if you are so inspired oncological surgeon or you're so aggressive, that doesn't mean that you save the woman's life, because you see compare the recurrence rate between simple conization and radical tracheotomy and the recurrence, and this study shows that there is no difference between them. Okay, let's move further. The real challenge of ovarian cancer. If you have ovaries with malignancy, you say that is end of your reproduction. Finish. You never will have a child. That's not true, of course. And let's look on the guidelines. See, for borderline tumors, it's quite enough to remove the one of the ovary where the process is, and to save the uterus and contralateral ovary. For sex stromal tumors, again the same with lymph nodectomy and of course assessment from Dr. Metodiev to see how it is. And of course you have very good built laparoscopically team to avoid rupture and to work with the back, not to increase the stage of the disease. And germ cells tumors, again, you don't need also nodectomy except in big stages. In these big stages, before 1C, you can combine with platinum-based chemotherapy. And you ask me what will happen with ovary. Perhaps they will be included and ovarian reserve will fail, but there is opportunity for this woman to this ovary to survive. And not only, you can have a frozen oocytes before that. And one of the discussion area in all guidelines is what to do with epithelial ovarian cancer with young women. So I think that we again have opportunity to try. Why? First, because these women is just only few. Only 12% of the women with epithelial cancer are in reproductive age, and you see this diagram. And you can try the fertility sparing surgery and see what the guidelines shows. But before that, let's say that how younger is a woman, so you can find the epithelial ovarian tumor in early stage, and this gives you opportunity to try conservative treatment and to preserve and save her fertility. So here is what can we do. Again, remove the tumor with together with the tube and make a biopsy. If both ovaries are involved, remove both ovaries with the tubes and preserve the uterus, because she will be able to conceive with egg donation. And this is a guide for early stages of endometrial cancer, and you see that mission is absolutely possible for this. And if the patient, that is a patient wish, you must try. Not only to say that making radical operation, you save her life. And really, preserving ovary is so dangerous. You see here on this diagram the recurrence rate in epithelial ovarian tumor for in blue, and you see that in stages 1A and 1B and 1C, they're absolutely the same. There is no difference. 1C and 1C2 also. And if we extract this and to see here and to see the death rate is absolutely the same in the group, and see that they are very small. And finally, ovarian endometrial cancer. I will show you our case with similarities. Here is here you see how is first of all, you must be absolutely sure that you don't have invasion in the mu invasion. If you don't have mu invasion, you are able to preserve this woman. And very important is also to know the type of the cancer. That is, again, we work with oncologists and with pathologists and make a decision together before to say what to do. But if you anyway go to hysterectomy for this, you can preserve her ovary. Why? Because after successful treatment, she can think about surrogacy or something like that. And she will accept your treatment better when she knows that she has a future perspectives for reproduction. This is the techniques for hysteroscopic techniques, how we do. That is Ivan Mazon, one friend of mine from Italy invented. It is 3 steps how to manage the endometrial cancer. And I will tell you, when I work with our case that I showed you, after the first resection, and when I pass inside together with a pathologist on my back, because they standing with me and said, take a biopsy from here, take a biopsy from here, take a biopsy from here. That is a team, that is a collaboration. But when I entered inside, I said, that never be uterus again. I think that everything is finished for her reproductivity, because the uterus looks like a totally destroyed. But you see, the endometrium recovery itself is absolutely normal. The pathologist confirmed that, and she became pregnant and delivery successfully. Of course, you ask how long is the treatment for this? The treatment is 3, 6, sometimes 8 months with very strictly to follow the case and to do more than 5 hysteroscopy to see how it is to remove adhesions and to have a biopsy from everywhere. And few words about now we are hero, we are we say fertility of women. What about the pregnancy? So the pregnancy, if you have a gynecological type of cancer and she really have a successful treatment, you must encourage this patient to conceive as soon as possible. And here comes the ART procedures, when you must say that is they dangerous for them? No, they are not dangerous for them. They are a highway. So ART procedure is the highway. That is a fast way for them to conceive. If you have before that cryopreserved oocytes or embryos, she can conceive. It will be a time of 10 to 14 days. The end is what will happen, for example, with the uterus or with the ovary if she has delivery successfully. It must be decided case by case. Of course, you must see what the patient wish and to speak with your oncologist, with your pathologist, what is the chances for recurrence of the disease and what to suggest the patient. It's easy way to advise her, I will remove everything and you'll be healthy and alive. No, think case by case. And of course, the challenge in front of our obstetricians, I'm not working obstetrics, but it's really challenge, especially after conization. It must conceive 3 months after this procedure, but after tracheotomy, it must pass 1 year before to try to conceive. And many of these women with after tracheotomy conceive normally. There is no need for assisted reproduction. And always you must pay attention for these cases, follow them very carefully. They're high-risk pregnancy because they have a risk for severe prematurity. They have a risk for abortion. They need sometimes to do laparoscopic circulation, many other things that we are doing in our hospital. But this is when you see the baby born from cancer patient. That's a real pleasure. We are happiness not only for them but for us also. And that's why how I said working in a team together needs high expertise in every unit. That's why we have a maternal fetal department very well for fetal morphology. We have a very good medical oncology, one of the best in Bulgaria. We have department of anesthesiology with experienced anesthesiologists to follow this patient. We have a very good department of surgery. How I said, we have a Dr. Atanasova. And of course, Department of Neonatology, because if we have a prematurity, we must take care about it. And Department of Radiology, if we need this treatment. And of course, the psychology is also important here. And for finally, pregnancy after ovarian cancer, the big question. Yes, you see here one study published 2 years ago that from 800 patients, 42% wish to be mother. And from then conception, they have successful conception 67%. And this results in 264 born babies from after ovarian cancer. That's a real good news. And I think that we must send this message to oncological surgery that are looking this session. Is it safe to stimulate? Yes, of course it is safe, but you must work with experienced infertility specialists to know what you are doing and know how to do it. You have a lot of ability to stimulate with different types of medication. You have ability also to stimulate ovaries, to remove the ovaries, and to make a pickup outside of the abdomen. That has different opportunities if you want to do things on right way and to save the reproduction of these women. Of course, for conceptions and for assisted reproductive technology after borderline tumor, just only a few cases, but in our hospital we didn't publish. We have 2 or 3 cases with successful pregnancy. This is one short study. And if we compare with breast cancer patient, you see that is absolutely similar. Every 3rd woman wants to be pregnant when she has a diagnosis cancer. And the last but not at least, we work very hard with our genetic lab, because we must take care about BRCA patient to have a type of endometrial cancer patient, and we're working very hard on this, and very soon we can have a genetic type of the endometrial cancer of the patient. We must take care about Lynch syndrome and many, many things. So think to be safe for the patient. And again, take-home message from the end: fertility sparing surgery requires multidisciplinarity approach. Fertility sparing surgery is for every oncological surgeon. Never mind what he or she think, they must that the fertility sparing surgery exists. Fertility sparing surgery is a different point of vision to cancer, because give the patient perspectives for future, and fertility sparing surgery exists. This is one of the end of my presentation, and this guy is not connected with my talk. This guy is invent something other, but you know, the people's memory are always on the negative side. We know very good who is Napoleon, who is Hitler now. They will remember who is Putin, for example, at the moment. People's data brought to people many disasters, but nobody knows or remember the people who brings happiness to people. And this guy, Bernard Sallow, invented the rolls of the suitcase, and everybody of us use his events, but nobody knows his name. That's why I'm always teach the audience from somebody who helps people to be more happy and more, and their life to be much more easier. So again, the fertility sparing surgery in our hospital is have one logo: back these girls in the game again. Thank you.